Good afternoon, everyone. Welcome to PCADV's Training Institute. My name is Danny Pettio, and I am the CLR attorney here at Pennsylvania Coalition Against Domestic Violence. Our webinar today is Double Trouble, Trauma and Substance Use Disorder, and it's presented by Dr. Ken Martz. And Dr. Martz is a licensed psychologist and clinical consultant. He is the former special assistant to the Secretary for the Department of Drug and Alcohol Programs in the Commonwealth of Pennsylvania. He has worked in treatment and management of a range of special populations, including criminal justice clients in the community corrections and in prison settings for the past 20 years. Dr. Martz has also worked in a variety of settings, including outpatient, residential, and therapeutic communities providing treatment of addictions, including gambling. Dr. Martz has a master's degree in clinical psychology from Loyola College, a master's of business administration from Argosy University, and a doctorate in clinical psychology from the American School of Professional Psychology. He has a number of publications and international presentations in the addictions treatment field. Just a few housekeeping items before we begin. You can download the materials if you haven't already yet done so in the files area, which the pointer will show you at this time. You can use the chat area also to type questions to our presenter, or if you have technical issues for our Training Institute. We will mute all users on our end, so please type questions in the chat box if you have a question for either the presenters or any technical issues you want to communicate to the Training Institute. At this time, I will now turn over the presentation to Dr. Martz. Thank you very much.
Hello, everyone. Welcome to the presentation. We'll be covering a wide range of materials over the course of the next hour to hour and a half. So I will be covering a bit of background information, some components of effective substance use disorder, brief overview of trauma and trauma-related work, and then we'll close by bringing that all together into the collaboration between the two. So just to start, so we're going to begin with some background information. Some materials you may have heard some things before. We'll begin just with some brief overviews. We started a conversation years ago. You'll see the chart on the left that begins to take a look at the past year initiates for specific drugs. And the top one on the left there is marijuana, followed by pain relievers, tranquilizers, ecstasy, inhalants, cocaine, etc. You hear all the time about the heroin epidemic. You can't go into the community these days without hearing about this heroin epidemic. Please understand, though, the context here that heroin is that little tiny box second from the right. Heroin is only a small portion of the problem. The larger piece there is the prescription opioid pain relievers. Now, that was from 2008, so clearly things must have changed in the last decade. So the newer data out of SAMHSA, they have changed that, although you'll see that there is very much the same pattern where heroin is still quite low, prescription opioid pain relievers are still quite high, although they have since realized that alcohol, cigarettes, and smokeless tobacco are factors to consider, so they've laid them out there alongside so you can begin to understand where these things all fit together. So just taking a moment here to see for the perspective of where these things all fit together, most folks, about 80% of those with opioids are using multiple substances, and so really being careful to understand the complexity of the cases. Just for another way of thinking about it, there's a strong focus, again, on the opioids. However, and it is, although it's costing hundreds of billions of dollars just for the opioid use issues and many, many deaths, there is a real concern, though, that suicide has also very expensive, many deaths associated. Alcohol still outrank overdose deaths, as well as tobacco. So again, remembering the context of how these things work together, and many times they may be occurring at the same time with the same individual. This slide here takes a look at heroin use specifically across the ages. This boring little slide is interesting to know that it's so boring, but it is actually flat. Although if you think about what the newspapers read, you'd imagine that there's a sharp spike in the heroin use. However, it is not. What's happening is that despite the relatively consistent rate of opioid use disorders, there has been a spike in the deaths associated. And so what's really happening there is about the complexity of the way folks are using the opioids and the spike in the way they're using, which opioids they're using, such as fentanyl, which is about 50 to 100 times more powerful than heroin. So when you start mixing that in together, it's a much more deadly combination and higher risk, especially for folks who are opioid naive. So for folks who are chronically using opioids, tolerance will help to protect them. But for example, at a high school or college, some folks might have been using some other substance and said, oh, let me try this. well, they try something a little bit more intense, it can be their first time using an opioid and still cause death. This particular slide is getting a little bit older, but it really hits an important issue that I wanted to highlight because it's not always reported this way. This is specific to Pennsylvania, and you'll see that some of the changes that's been happening there, the percentage of heroin use, it is still quite high of those using heroin, but the change, the part that's going up, you'll see the sharp spike in fentanyl. It is, in the last year, actually overtaken heroin to be the #1 drug to overdose deaths. And you'll, as you note below, there's a wide range of other medications and other substances that folks are using as part of that, their substance use spectrum amongst their death situation. Some of the newest data out there from the Coroners Association reported by the DEA takes a look at different ways of breaking it out. As I mentioned, fentanyl has moved up to the top, which is why you see it on the top there. This graphic gives you a sense of what age groups are going on here, and you'll see the striking rise, particularly of fentanyl, particularly among 15 to 24-year-olds. So this is a concern for folks that, especially that are earlier on. Historically, we think about substance use disorder in kind of there's different pathways. The folks that start in youth, and there's other folks who maybe didn't have anything until later on, have a late onset, and then maybe had a back issue, had some pain medication for the surgery, and then got exposure much later on in life than some of the other traditional pathways. This is also from the Coroners Association. One of the things that it breaks out nicely, you'll see the little blue line there. Once again, those are the folks who had heroin alone. They're by far the minority. Spike that's going up is all the folks that have multiple substances. The nice thing they did there was that they broke out all the other substances that were included in the toxicology, and you'll see other things like methadone, OxyContin, fentanyl, morphine, other illegal drugs such as marijuana, cocaine, other sedating drugs such as alcohol and benzodiazepines, and also antidepressants such as Prozac, Celexa. Wait a minute. So if these folks are on the streets, why are they getting them antidepressants? So as you begin to look at what's going on here, you can begin to understand that some of these folks are coming into our contact and coming into our care. We have the opportunity to make a change here, working and just beginning with the folks that we're seeing every day. Just for a sense of context, these are the numbers of sheer overdose deaths in Pennsylvania over the last 5 years. The most recent data we have is 2017. We are now up to 5,388 deaths. This is not just 5,383 individuals. These are 5,388 families who have lost our mothers and brothers and sisters and children. It's doubled over the last 5 years, more or less. It's very troubling, and need to begin to see why is this going up. Also being careful that we don't become numb to this. It's become so widely reported that it's really easy to get into an attitude that, oh my gosh, it's just everybody's getting worse, so, you know, there's nothing much I can do. It's really easy to get overloaded and fatigued. This is the same material, although it's reported in a different manner. So this is the rank of Pennsylvania in the rate of overdose deaths. Unfortunately, this is not something we want to be climbing in, so not only is it getting worse across the country, it's getting worse in Pennsylvania. So this is a very serious concern and very sensitive to us in Pennsylvania. It does not have to be getting worse, though. The question I would always begin to wonder about begins to come to the next slide. This slide begins to take a look at the range of which counties, and I know everybody starts looking immediately to find your own county, which counties are getting worse over the last 3 years, and which counties are getting better. You'll notice the red marked counties. Some of them have 64% improvement rates, 27%, 67% improvement rates. On all corners of the state, folks are improving in their overdose rates. So what are the counties that are in light yellow doing right, and what can we learn from them? I don't have an answer to that, but just begin to think about the questions that might be useful so that we can find solutions that are effective. It's always best to look at folks who are improving to learn what we can learn from them rather than the folks that are getting worse and who may be highly motivated but have other challenges that they may be facing. So how did we get here? This all began many years ago with a letter to the editor. A letter to the editor published in New England Journal of Medicine. Recently we examined our current files to determine the incidence of narcotic addiction in 40,000 hospitalized patients. I'm going to skip down a little bit. We conclude that despite wide-range use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. This has become the famous Porter and Jick article. Okay? So this was many years old now. This had nothing to do with many things that we would begin to think about. But what happened now? So this was the full article that we just read in a few seconds. A 1989 monograph from National Institute of Health identified folks and asked them to consider the work of Porter and Jick. 1990 Scientific American called it an extensive study. I don't know about you, but I've seen other studies that are a little more extensive than that. 1995 Canadian Family Physician called it persuasive. Time magazine said it was a landmark study that the exaggerated fears of people becoming addicted to was basically unwarranted. 2007 textbook Complications stated that this was a landmark report that did much to counteract the fears that pain patients would become addicted. So here across the community, we have folks sharing this information that says, oh my gosh, OxyContin is safe. And in another spectrum, we've seen the smiley faces every time you go to the physician's office. They ask what your pain levels are, because we don't want you to be in pain. So we begin to prescribe this safe medication. We'd like to think that this was a new mistake. However, there is even more history than this to know that there was a time when we used to have cocaine in Coca-Cola. There was the Bayer aspirin company used to offer Bayer heroin as a cough medication for children. In the 70s, benzodiazepines were marketed as mother's little helper. So very often these medications can be out for a while before we realize the risks that are associated. And so we need to watch before the next wave of the next miracle drug comes out to save things and change things. Warning signs. I feel like I'd be remiss if I didn't spend a moment just to talk about the overdose issue, since we're in that spectrum here. If someone were having an overdose, essentially what's happening is an opioid is a sedative. So as it sedates and sedates your respiration, sedates and sedates your heart rate, that's the types of symptoms that you would expect to see. Slow or shallow breathing, very sleepy, unable to talk or even unconscious, doesn't respond to attempts to rouse consciousness. They may start turning blue or gray in their lips or fingernails. They might even get, I can't produce it, but it's kind of like a snoring or gurgling sound. It's almost like gasping for breath. If you really want to think about this is the breath getting so shallow that it's really difficult to breathe. So things to do, check to make sure there's no response. If they do respond, keep them awake, call 911. If you have Narcan available, it's overdose response medication. That is an excellent tool there. You can get Narcan, naloxone. It's pretty widely available now. Just go to your local pharmacy. You would be able to get it at the cost of whatever your prescription or your copay is. There are different types associated. The most common one right now, you'll see on the lower left there, it looks like a little nasal spray. You can just place it in the nose and spray. There is also the auto-injector is the lower one, image on the right. It'll talk to you and tell you how to walk you through an injection, essentially. So how does one become addicted? Just for a word of context again here, begin to remember that this is, again, a complex illness, so there is no single magic bullet solution. There is a genetic vulnerability, biological vulnerability from genes, from biochemistry, etc. There's psychological issues from trauma, cognitive beliefs, mental health issues of various sorts, social issues. We know that family influences, peer pressure, cultural differences make a big difference in the range and rates of substance use disorders. There's emotional things. We can't underestimate the feelings associated. And if you've ever been angry and it starts and gets you to do something you might not otherwise do, or guilty or shamed, and again, doing things you might not otherwise have started. We've also found that the spirituality is a protective factor as well. So each of these, begin to think about prevention. Whatever elements work for the individual, find the combination that supports the individual to have a solid process. So a couple of words on prevention. National standards taking a look at prevention begin to take a look at the individual efforts, the peers, the social, and community. So you can have multiple spheres of effectiveness there. Each of these risk areas can be improved over time. One thing to be careful of is to avoid fear-based approaches for a number of reasons, one of which has to do with trauma, being trauma sensitive, but another factor is that it simply doesn't work. So imagine, just the simplest way I can explain this is if you have two children, one who is the I'm going to make broad brushstrokes here. The child who is towing the line and is anxious and is already going to be very strictly rule following, and you have another child who likes to take risks. Okay? Well, if you give a fear-based approach and tell these children that something is risky, the fear-based child is already not going to do anything differently, so that doesn't help anything for them. But to the child who is a risk taker, who is a person at risk for substance use disorder, you just gave them something that will be enticing them to engage in that. So being very careful to avoid fear-based approaches for prevention. There's many of these out there, and I won't list them specifically, but begin to be just thoughtful about that. What you do want to do, though, is skill-based. How to help kids understand what the coping skills are. How do I deal with it when I get depressed rather than trying to go get a drink? How do I say no to my peers when they say, hey, why don't you just try this? The other thing that's very important is to use very clear, strong no messages. If you have soft no messages or supportive messages, it is problematic for prevention. They'll be more likely to use. For those who want to look further into this, there are several resources out there. One was the National Registry for Evidence-Based Programs and Practices. I believe they were just closing down that website. Well, there's also the Blueprints program and the Washington State Institute for Public Policy. Each of these locations has lists. They have cost-benefit studies on the various. There are hundreds of different prevention programs that can be utilized. You choose the one that's appropriate for your population. Let's talk briefly about this, how one becomes addicted, because one of the things I've found over the years is that no one wakes up in the morning and decides, hey, I'd like to be an addict when I grow up. I'd like to go live under a bridge somewhere and struggle like that and have to steal for my next meal. No one wakes up like this. So most people start off in the top left corner there, in the green area where it says no addiction. And maybe I have no drinking, or maybe I have a social drink. I just want to relax for today, or I had a bad day at the office. My gosh, I need a drink. And so now I go get a drink, and by the way, it's happy hour, so it's 2 for 1. So you see how you begin to go down this little slope here. And now it's 2 for 1, and then another day I start driving back home and the police catch me and now I have a DUI. This is not substance use disorder yet, by the way. This is a problem associated with alcohol use in this case. So at this point, now I'm really stressed, and so now I really need a drink, and now my boss is really getting on my case because I have to take all this time off work to go to these education classes for my alcohol, and now my family circle is nagging me about this. So you see how this can begin to build. So it doesn't necessarily wake up one day and it's an on-off switch. There can very often be a slow progression as then you start to withdraw from positive peers, have disciplinary action at work, maybe have increasing health complaints, become more isolated. Before you get to the bottom, which I use the phrase rock bottom in quotes because it's one of my pet peeves. Rock bottom gives the implication that you cannot get worse. There is no bottom except for death. Our role as clinicians and as supporting individuals is to catch folks wherever they're at, engage them and help motivate them and catch them and bring them up before saying, oh, you need to come back later when you get worse. Arrest, divorce, loss of job, depression, suicide, and death. So you can begin to see then that the people will begin to move into early recovery and late recovery as that practice builds over time. And you can also begin to see, this is not diagnostic there, but you'll see in the center kind of an outline to say that, when you're talking at the very tops of the V, you're really talking about prevention type services or outpatient services. And then you get to a little further, and at the bottom, you're really looking at more like an intensive intervention. So just kind of a thumbnail to understand where the individual and how to begin to work with them and what context might be useful for them. So what's all this talk about a brain disease? I've been talking about research a little bit. Now I'm going to talk a little bit about the brain. And don't worry, I'm going to make it translated into English so that it's as understandable as possible. One of the people out there to know about is this ASAM, the American Society of Addiction Medicine. Their definition of addiction is that it's a primary chronic disease of brain reward, motivation, memory, and related circuitry. It's very important to notice here what is included in this definition, what is not included in this definition. This definition does not say that you have a deficiency in a certain brain chemical. Okay? So what's going on here is a process function in the brain. So we'll begin to try and make that make sense. So again, for very simple terms, this is your brain. Okay? So you have a cell connected to other cells, connected to other cells, et cetera, et cetera. So I have an urge to use, and I have two brain pathways connected to that. There's a decision to use, a decision not to use. Okay? So I will decide to use, and I will go get some money. I'll go to the dealer, or I'll use, and that wears off, and I crash. Now that was so much fun. I'll do it again tomorrow, and again, 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 and again. So by the time folks come in to see us, they will have practiced this behavior many, many times. So now this is not a trick question. Which of these two brain pathways is stronger, the one on the left or the one on the right? Okay, very simple. You too can understand brain science. It's very much like if I want to, my daughter is learning her times tables, and you repeat the times tables, repeat the times tables, you repeat the times tables, you repeat the times tables. It becomes an ingrained memory such that I'm never going to forget the times tables until I have either a serious brain trauma or dementia or some other very serious brain injury. So once something is learned and overlearned, the brain pathway, there's a saying that neurons that fire together wire together. So what starts to happen is in the early stages of addiction, you might have like a little indentation, like a little riverbed. So they've been practicing for a while, they might have like a Mississippi River. Over 5 years, by the time they're coming in to see someone for treatment, you might have a Grand Canyon carved in there. So this is, in simple terms, the disease model of addiction. The disease model of addiction says three things. So one of which is that it's fatal. We've certainly talked about that. The second is that it's progressive. You see how it continues to get worse. And if I stop for a while and I start again, you see why there's this good conversation. You pick back up where you left off. And the third, it is chronic. That once I have a Grand Canyon, it typically stays there for a while. Okay? So, oh my, that's depressing over lunch. So let's be something else we can do with this. Since we can't get rid of the Grand Canyon, what we can do is perhaps build a dam. So I've been to the Grand Canyon. It's very beautiful there, and I can happily live my life in Pennsylvania and never go back to the Grand Canyon again. And so this is what we do. We build a dam, and then we begin to go over down the pathways on the right side there. The graphic is not showing up as clearly. So you begin to go down the pathway for a day of treatment, 2 days of treatment, 3 days of treatment, until suddenly your insurance company tells you, you're cured, go home. You have now been cured. You now have this stage where I have not yet fully learned and ingrained these new skills. Which of these two brain pathways is stronger? So you begin to see why the number one predictor of outcome is length of stay in treatment. The amount of time that I engage you and get you practicing the skills of recovery, the skills of rebuilding and engaging in life, the more likely that you'll be safe and stable long term. Now, I'm not going to spend a lot of time on this, but there are hundreds of neurochemicals, and they all have fancy names. But for example, when you're going down these neural pathways, you're also engaging each of these, firing off each of these different fancy named neurochemicals. There's the anticipation chemical, the excitement chemical, things that you might have heard of like adrenaline, these things. Hope chemical, the rush chemical, the oh shoot chemical, or the I hate myself chemical. And so what begins to happen, in addition to the neural pathway pulling you along like a strong riverbed, you also have the internal chemical process that starts to pull me back to this old familiar place of hating myself, this old familiar place of depression, and how to begin to unhook from what you can begin to think of as a draw towards, or even an addiction to, these other moods. And the mood swing cycle as it goes, the roller coaster of the mood swings. For those that like visuals, I'm a visual person, you begin to see there's a number of these out there. The left shows the cocaine substance use disorder. The person on the left is actively comparing for cocaine. Oh, I'm sorry. The one on the left is the normal subject. That would be you or I, sitting out there with our highly functioning brain all lit up. The person with cocaine, 1 week in recovery, you can see that their brain has much lower functioning, that over a couple of months, the brain begins to heal. And this continues just like other brain injuries. Up to a year, 2 years, the brain will continue to heal if you stop putting the chemical into the body. Now, once again, this is, I believe, the last of the PET scan. These were the SPECT imaging. This is, again, your normal healthy brain. It looks all nice and colorful. The lower left is your brain on substance use disorder, and the one on the lower right is your brain 1 year drug and alcohol free. You'll see the one on the lower right is not quite as fully formed as the normal brain, but it is far improved than when one is actively in addiction. The brain does heal, recovery is possible, and recovery is actually the expectation. Now, for those that like these sorts of things, they also have samples of these from the long-term alcohol abuse, marijuana, frequent heroin use, folks, and as well as someone who had 10 years of heroin use had stopped that and continued for another 7 years on methadone. So we begin to understand that each of these things has a role in how it affects the brain in different ways. So what is this thing called treatment, and what does this recovery thing look like? So we begin to think about treatment goals. So I want to begin to think about this as a spectrum. On the far left, you have an illness. I'm sick. This is when you have the flu, you stay home, you stay in bed, you call into work and say, I'm too sick, I can't come in today. So in the middle, you have the next day, I am no longer having the flu. I'm going to go back to work, but I'm still not eating right, not sleeping right, not exercising, not washing my hands, and all of a sudden now I get the flu again. So I'm highly at risk. Versus any one of us on a given day has been exposed to about 2 billion germs, and yet we don't get a cold every single day. So what's going on there is what we have this concept of wellness, where our immune system is able to fight off the at-risk issues. So changing the terms here, so we're going to change the terms here. So the far left is active addiction, active substance use disorder. So if I stop using my heroin today, tomorrow, the day after, 3 days after, I am technically abstinent from the substance. Anybody that I say that to will immediately understand that the person is highly at risk of sliding back. And this is why I want to begin to understand, again, that this is not a black and white, it's not an on-off switch. This is a spectrum from active use through this thing called recovery. Recovery is an active verb. It's an active process of maintaining and engaging in behaviors that will keep us well rather than at risk. And so this is something I would often have conversations with my clients is, how much of a risk are you willing to take with your recovery? And if you want a little bit more stability for yourself, for your family, etc., what are some other things we can put in place so we can get it as safe as possible for you? So changing that language a bit, so you have a range of behaviors that this is working through, from a chemical addiction through withdrawal to what we can call an addiction to recovery behaviors, from dysfunctional relationships where I steal from my loved ones and lie and cheat, to I've stopped using but they don't trust me yet, to developing a trusting relationship, partnerships, respect. You see why, again, these things take time. The number one predictor of outcomes is length of stay in treatment. If I kick you out in 3 days, you haven't had time to build all these protective factors that will support you. Unresolved grief through awareness of loss, being able to process that and let go of the grief and trauma of the past. So you see why, again, this is the range of material. This is the process of what goes on in that black box of therapy, where we're engaging things and unpeeling things that sometimes may be unknown to the client immediately. Sometimes they may just be it may be too traumatic to share immediately. So for example, I've worked with clients before where we've been working for a while, developing a relationship for a while, and it's not until 6 months later where they say, okay, well, let me tell you about this one thing that I'd never told you before that happened when I was a child, that they didn't want to bring up, they didn't want to share just yet. And so the relationships happen in the context of a safe and healing, trusting relationship. This critical element, not only for substance use disorder, but also for trauma-related issues. Just to repeat one more time for those who like the numbers, you can see there's a direct linear relationship. The number of days in treatment, the better the outcomes. So you can decide if you want low outcomes or if you want high outcomes across studies. The one in the middle is actually a Pennsylvania-based study. The one on the left are 3 national studies. It's a meta-analysis of major studies across the nation. Clear relationship that if 90 days or less, and NIDA says this, 90 days or less is of limited value in terms of benefits. So what is this treatment thing? So I want to begin to have a context that it should not be confused with supportive services like detoxification or withdrawal management. That's just simply getting medically stable. It is not about the medication. There's no medication that's going to heal my trauma. There's no medication that's going to fix my relationship with my spouse. It is not about peer support. Although peer supports and 12-step programs are very valuable, it's not treatment. It doesn't take the place of treatment. If I have cancer and I go to a peer support group, my outcomes improve if I go to the peer support group, but I wouldn't do the peer support group and not go to the chemotherapy or the other medical treatment as well. These are all supportive services that work together. Housing, etc., getting them jobs. These folks had jobs before they lost their jobs, so getting them a job is not going to fix things. Getting them a house is not going to fix things until you get them stable first. And so that's really what the treatment process is, really working to address the trauma, the coping skills, the relapse prevention skills, all these pieces so that they can go back to fully living life. Now, transition timeline, people will begin treatment in a whole range of ways depending upon the severity of how far they went down the V chart. First thing always begins with an assessment and referral to an appropriate treatment program. For those who are most severe, it might be that they might have several months in a residential program and then step down to an outpatient program, step down to intensive outpatient, then regular outpatient, and eventually just to a peer support over time. And begin to think about this over a 2-year period. Remember I mentioned about the brain having 2 years to heal. And actually, if you can get, just like cancer, if you can get somebody to 5 years, there's an increase in recovery rates such that if you can get somebody to 5 years, it's 85% likely they're never going to use again. So there is really need to begin to think about what measures are not just saving lives, but getting folks from the bottom of addiction all the way forward into recovery where they will stay stable, their families will be recovered, and it will stop the cycle of addiction that would otherwise be passed down to their children and the next generation. The challenge one of the challenges we're having right now is that we are having so much impact from a repeated generation. So people are using, they have children, they overdose and die. And now what happens to the children? And they start into a pathway as they go into foster care, as they go into kinship care, as they go into other stressors. Just so folks have a language and know what's out there, one of the most common approaches for substance use disorder is cognitive therapy. The idea is that behaviors are motivated by beliefs, and so part of your practice is to change the belief patterns. So for example, there are specific generating beliefs such as, I can't do anything else. I need this drug. I can't survive without this drug. You know, it's easier to avoid life problems and just go use some alcohol for a while. You know, it is easier for the next hour, but that's not going to help me to maintain my job and my family and my life. So really beginning to help them to unpack what their beliefs are that are keeping them stuck within the addictive process. I mentioned briefly that peer supports are very valuable. There is research out there. There's some folks out there trying to say that peer supports don't do much. Peer supports are very valuable. The more engaged someone is in a positive peer social support, the more likely they have ongoing abstinence. So just to kind of outline, just to summarize some of those pieces briefly, some of the key issues to begin to think about, the therapeutic dose is the proper level of care. Don't give somebody outpatient when they need residential. If they only need outpatient, that's great. But if they need residential, they're not going to get better. So for example, the analogy is there, if you have penicillin, and you know that everybody needs 10 days of penicillin, but you give them 1 day's worth instead, they'll actually get worse. So the intensity is appropriate. The length is appropriate. So you have the proper dose of medication and proper duration of the medication. And in treatment world, it's also a continuum of care is also the third prong, which is really well known. So you don't, if someone needed residential, you don't just kick them out and say, okay, you finished your residential. You step them down to intensive outpatient and you step them down to outpatient. So it's kind of like going from training wheels to a bicycle before you start on the unicycle. Then there are also quality issues such as using evidence-based practices, things like behavioral counseling, cognitive restructuring, emotional supports, these types of things. Making sure you treat the different pieces of the individual from their thoughts, their feelings, their trauma involvement, their trauma history, case management, and engagement so they can access the supports that are out there. There's comprehensive care elements that we mentioned. So they're on the side here that are very valuable. I certainly recommend, and we certainly would want all of our folks to have positive peer supports, whatever that looks like for them, employment and housing, and really moving towards motivation and engagement all the way throughout. So what does this thing called recovery look like? I mentioned this a little bit before. Within the first 12 months, the recovery rates are much lower. By the time you get to 1 to 3 years, 2/3 will be able to maintain their recovery. Later 4 to 7 years, it moves up to 86%, and then it kind of levels off a bit there. Most of the folks that I've ever worked with that have had a long-term recovery, such as 5 years and longer, I have rarely ever had somebody come back with a relapse after that period of time. In the rare occasion that it has, there's been some sort of unique trauma that had occurred. My brother just died, we were just in a car accident, et cetera, et cetera. So usually there's something going on that would spark a return at a much later date. Otherwise, once you get engaged, that's supported. So recently there was Faces and Voices of Recovery is a national organization of recovering individuals. They did a survey of 3,200 individuals with an average of 10 years in recovery. You may hear a theme from me that let's begin to look at what's working for the people that recover to begin to get lessons. The majority of them identified, 75% said that they are in recovery. So again, you hear that the thinking is, I think about this as an active process. There's only 14% or 8% that say that there was a past issue that they chose recovered as a past tense. 3% identify that they were in medication-assisted recovery. So begin to think there are many pathways to recovery, and they're each valuable, and however you get there, I don't care. What I do care, though, is from a policy perspective, from a broad brush perspective, where are the areas where folks are being able to get there? Again, 71% had a professional addictions treatment. Some do not, and if they don't, that's great, but begin to think about where will you make recommendations. 95% had been to a 12-step fellowship like an AA, NA, et cetera. 18% had gone through medications, and another 22% had other peer support groups that are non-AA. So these are usually secular, so the non-spiritual, non-religious peer support groups. So there's a wide range of them out there. There's just not as many of them, so it's a little harder to find them. Now, just a word on this thing that you hear out there about confidentiality. This is a big deal in the substance use treatment world. We know that over a long time now, the federal is 42 CFR Part 2. And that's the federal regulation for substance use disorder confidentiality protections. It was decided even back then that there was a challenge with people, not being able to get jobs and housing and all these types of various discriminations by virtue of having their substance use disorder. And so even today, in the most recent NAMSA publications, 2 of the top 5 reasons why people don't go to treatment. First one is a belief that I don't need treatment. Next issue is I can't afford treatment. 2 of the additional top 5 are stigma related. I'm afraid of what people will think of me. I'm afraid I'll lose my job if I go to treatment. Confidentiality remains a huge barrier to folks being willing to access care. And so when we talk about maybe we should loosen these confidentiality protections so that we can better protect people, understand that it's one of the major risks of why people are not coming in to see us in the first place. Actually, within the regulations itself, it's identified that it is the purpose of the regulation is to increase the likelihood that they will seek care by protecting them. The key one on the right here is central to this whole conversation today. The intent of confidentiality is to create a safe environment for self-exploration. Clients are often unwilling to tell me something for a period of time until they trust me, much less 1,000 of my closest doctor friends that goes into a medical record. Or particularly with substance use disorder, that I'm afraid that there will be a criminal charge associated with some of the things that I've done in my past. So you see why this is critical for substance use disorder protections. It is also important for trauma issues as well. Safety, safety, safety. Creating a safe environment where folks can explore their deepest secrets and deepest shames. One other quick statistic here on the substance use side. We tend to think about those people as they don't recover and they're just bad people. The reality of it is that the recovery rates for substance use disorder are just about the same as every other chronic medical condition. Behavioral change is difficult. It's very easy. We all make our New Year's resolutions. We're all thinking about that now. And we plan to go to the gym, and we sign up for a gym membership, and by the 3rd week in January, we stop going. Behavioral change is difficult. And so we need to be careful about we don't shame people for, in this case, substance use disorder, but also the persons with diabetes who continue to have a piece of chocolate cake someday, or the people with hypertension who continue to smoke. While there are concerns and risks associated with this, and I'm not saying that to say that we encourage them to do that, just understand that we're not shaming for what is a wide-ranging challenge to change behaviors. Those that like statistics, again, we say that we can't afford the treatment thing. You might hear that from an insurer or some other folks. We can't afford not to treat folks. The national data begins to look at the Cal data study as one of the most widely cited. There will be some statistics that are a little bit higher, a little bit lower, but 7 to 1 is about the standard that's understood out there. You'll see it in the lower left there. That's cost-benefit ratio. The cost of treatment versus how much is saved to folks by getting into recovery. They took a look at that across multiple modalities as well to see what the range is there about what other medications or treatment approaches and modalities, so you can begin to think about things in a level of where their benefits are. So just think about this to bring this all together. One of the ways to apply this is I like to think about this as again, not as a black and white on-off switch, it's as a balancing, as a scale. So think about where is this individual on their length of substance use disorder versus length of recovery, just like the brain imagery. The negative peer pressure versus positive peer pressure. So trauma versus trauma resolution, secrets versus trust. So where are they in each of these areas from lack of hope to having a hope and goals and vision towards a life? So, and they may be at different stages at each of these, and that's absolutely okay, but you begin to have a way to think about where folks are at. So transitioning a bit to your brain on trauma. So this is, again, your healthy brain and the brain on after physical abuse. So you begin to see how, again, the brain is impaired over time of abuse. This is not only from physical abuse, but you also find similar types of things from neglect. Without going too much into the fancy terms of it, but it's out there if you're interested, it affects this anterior cingulate gyrus, it affects the basal ganglia, which is about anxiety, the limbic system, which you've heard about as emotional control. So there's a wide range of impacts all across the brain system from being exposed to trauma and adverse experiences. But I want to begin to think about how these start to relate together. They really are a concentric circle construct. So you begin to see how some of the challenges that we talked about in the drug and alcohol side will begin to develop as a theme as we talk about through the trauma side as well. A couple of things to think about for trauma and just for level setting again. The term trauma refers to experiences of intense physical or psychological stress reaction. It could be a single event, it could be multiple events, or a set of circumstances where you're really, there's a fear of harm. Think about fight or flight. So there's a risk associated there. Trauma-informed care is a big buzzword these days. One of the pieces to think about there's really no reason not to be thinking about trauma-informed care at this point. How to have an environment, again, that you've heard me say a couple of times already, you might hear me say it again, that is safe. You want to have an understanding, an understanding among the staff that if I start to scream at a client, that's going to have an effect. And since many of our folks walking through the doors have been exposed to trauma, that can be very triggering to their trauma history as well as creating a relapse risk. So how to begin to have a safe and create a safe environment, an empowering environment. Versus trauma treatment. These are evidence-based practices that really deal with the recovery from the trauma itself. And so I can have a recovery-informed environment at many locations, but that's not the same thing as doing trauma treatment. And we'll talk along the way about when and where and how the trauma treatment as well. I began to mention about those different types of traumas. It might be a single event. So a single traumatic event, I see I'm in a car accident and I almost died. It could be a recurrent event such as an ongoing domestic violence situation, or it could be a sustained experience such as I've been off to the war. And so I've been living in a chronic sustained experience for days and months and years on end. There's various sources such as natural disasters, accidents, and of course intentional things such as crime, child abuse, domestic violence. Now, we talked a bit about the brain pathways issue, and you begin to think about what the brain pathway issue is. From this perspective, it would be more like a chronic traumatic experience. So you'd be either thinking about neglect, ongoing domestic violence, or ongoing child abuse. That would build into this type of a brain pathway. But there is another. So the other is what's known as flashbulb memory. So, for example, some of us are old enough to remember the old cameras where it would have a flash, and a few seconds after you had the flash, it's like you're blinded for a moment because it just kind of burns into your visual cortex and your eyes. So this is a natural thing in our biochemistry. So, for example, you touch a hot stove and you immediately jump back and scream, ouch. And your brain immediately ingrains that. Instead of waiting to carve it in over months and years, your brain immediately carves that traumatic experience in to protect you so you don't go back and touch the hot stove again. It's a flashbulb memory. So one is the chronic pathway to these traumatic ingraining in the brain, but there is also an acute pathway, the flashbulb memory, and that's, again, a single-time violent assault can also be ingraining and very quickly that you begin to filter behaviors with thereafter. The other graphic that you see here is that there's other elements associated here. What gets encoded is not just the person who was causing the abuse, but the event itself. It's not just being physically assaulted. There's also the experience of it. There's the feelings of shame, the feelings of guilt, the feelings that are associated, and the effects. So what happens after the assault, and how do I act differently? How do I act differently with my family and friends and colleagues, and do I keep it a secret, and these types of things. So this all begins to then get ingrained and encoded into that traumatic event. So begin to think about, from the domestic violence perspective, there will be a couple of different ways that this will overlap. From the offender perspective, for those who have been domestic violence perpetrators, most commonly it is either alcohol or cocaine. Actually, opioids and cannabis are not as associated, although things can happen, they're not as common with being a perpetrator of domestic violence. So if you think about that just very simply, if I have an opioid, it's a sedative, so I'm going to go to sleep. I'm not going to go and get more aggravated and go start injuring someone. Versus alcohol, which if I have internal anger, the alcohol immediately turns off the frontal lobe, which would otherwise prevent me from doing impulsive behaviors, so I'm more likely to act impulsively on that angry urge. Same thing with cocaine. Cocaine is activating, and so again, it can lead to that irritability and increase that risk. On the other side of substance use disorder, of those who are the victims of domestic violence or child abuse and these other associated risks, the substance use might be used as a numbing or as an avoidance, as a way of dealing with that intolerable pain and memory, as a coping mechanism. So some principles to remember about this. Sometimes environmental or situational cues can trigger the memory of the prior traumatic events. And so you think about the brain pathways that we looked at before. What gets ingrained in there is not just the substance use or the trauma, but how did that person talk to you? What clothes was this individual wearing? What room was I in? So the entire sights and sounds and smells of that traumatic moment, particularly with the flashbulb memory, are ingrained there. And so I might start having a smell that starts triggering me that I'm at risk, and I don't even know what's triggering me. Or I might have a sound or a tone of voice that a judge or a lawyer or a loved one gives me that tone. And so this is all a part of how to be trauma-informed, kind of understanding the ways that I may inadvertently trigger something unintentionally, and how to begin to have that sensitivity to it. Sometimes these responses are not manipulation, but just a reactivation of the best strategies that individual had learned to survive. So they might start denial or avoiding or lying or drinking alcohol, because that's the best way that they learn to deal with the intense stress of the situation. Many adverse effects experiences occur in childhood, but many can begin later. So we'll talk about that as we get to the intersection again. So for example, the substance use, those who never had a traumatic experience after being involved in substance use disorder can also develop traumatic experiences. They went to purchase drugs and someone pulled a gun, or some, situations occurred or violence occurred as a result of being engaged in the things that come along with substance use. So what are some things that I can do? I can begin to think about working with clients collaboratively rather than directively. So begin to have conversations like, what are some choices? What are some things you can do? So you begin to help them have options, which is very empowering as well. Create opportunities for collaborations, just simple things even, such as what name do you prefer to be called? How should I address you? Do you prefer this or that? There's ways you can engage and help them understand that I'm not just going to sit here and tell you, you shall do this, as which may trigger some of the experiences that they've had with someone who was very controlling in the past. So being careful to prevent re-traumatization, monitoring for situations and events and reactions that may trigger the traumatic memories. But think about that also. Remember the distinction about trauma-informed care versus trauma treatment. I don't want to be opening up the traumatic memory until I'm ready to be dealing with that traumatic memory itself. So I want to begin to create a safe space before I'm going to purposely work towards any of those other issues, which may not be until much later. So for example, one of the common evidence-based practices is called seeking safety, is a practice about, and she'll say this in the manual, that you may be working for 6 months, just working on the tools and skills to make a safe environment before you are going to begin to open up the trauma itself and so we have the coping skills with which to manage them. Manage the triggers as they arise, build trust and resilience, acknowledge grief and bereavement. So there's losses associated over things that I haven't been able to do in my life because of the ways that I've been so busy protecting myself. A number of strategies to work on pacing and timing. So one thing that's very simple, just discuss and ask feedback from the clients about how the pacing, just openly and directly. How are we doing here? Do we need to take a break? Do we want to slow down? Are you starting to feel a little overwhelmed? We're going to talk about this or that today. If you start to feel having intense feelings, just let me know and we can take a break or things along the way. Use the barometer of intensity you want to scale things so you have check out the intensities. Slowly increase the intensity of interventions and continually adjust over time. So you're not jumping again from training wheels to a unicycle. Slowly moving folks along the way. Just to know there's a wide range of things out there, particularly in pain management, but I'm a strong supporter of whatever works for the individual. Find the combination that works for them. There's acupuncture, massage therapy, yoga, meditation, visualization, hypnosis, grounding techniques. There's a whole range of other complementary supports as well. And some folks will find that there's one that they just click with and it works for them, so go for it. You know what I'm saying? Psychosocial approaches, we've begun to talk about cognitive therapy. It's a little bit different in the context of trauma, although there's some parallels there. We're reframing the belief about the prior situation, but for example, sometimes a child who's abused believes that they're responsible for the abuse. They believe that Dad beat me because I was naughty. You know, okay? So the cognitive therapy is about how to reframe this understanding from adulthood that no, you were the victim here, not the cause, or you weren't responsible for the adult behavior. And so similarly, there are evidence-based programs that are really cognitively behaviorally grounded. Two of the most prominent ones are Seeking Safety and TREM, the Trauma Recovery Empowerment Model. There are a number of them out there, but those are a couple of the more common ones. So I'm going to spend a little bit of time also on the interlap of some of these, and then trying to save a little bit of time for some questions at the end. Begin to understand, again, the spectrum here. I have an experience of stress, and then the opioid receptors get activated, and I'm not going to go into all the acronyms there of norepinephrine but all the cortisol, all the chemicals that get related when we get activated in traumatic events. The use of opioids binds with the receptors and calms you down. Remember, it's a sedative. And so it causes relief over a short term, but it's not necessarily a healthy relief to go to use an opioid to deal with the experience of stress. So we begin to get this circular pathway here that really works on both the same pathway for both the traumatic event, that I have a traumatic event that energizes me and then I start to come down, but then I go down so low, I'm getting depressed and like a PTSD, you've got that back and forth spectrum. So the use of the opioids actually exacerbates and begins to, again, be a risk factor for that same cycle of roller coaster of the traumatic memories and traumatic internal chemicals. So one other thing to think about there is that sounds like it's something I shouldn't have to say, but opioid use affects the brain. You know, most of the time when I take an opioid, they say, warning, watch when you're going to go drive cars and watch when you manage machinery. Opioids impair memory formation. So if I'm sitting there trying to do cognitive therapy formation, trying to create new memory formations, and they're still using an opioid, they're still actively using, you begin to run the question, I've had someone ask me once, and I don't have an answer for this, should medication-assisted treatment where you were using an opioid as part of the treatment, how does that work with this in the context of trauma? And now, the whole medication-assisted treatment is a larger conversation. The medications are very valuable. It's absolutely life-saving for the right individual, at the right dose, at the right time, and the right duration. But again, begin to think about that's different than saying on it for the rest of my life. It's different for effects about how and when I'm on it, and how and when do I time my dealing with the traumatic events as well. So begin to think about that as we continue to work that a little further. This is, again, that concentric circles. There's three kind of pathways, one of which is I could just start off with opioid susceptibilities because of my pre-PTSD past, or it could be the reverse, that I have opioid use and that creates a risk for PTSD. The common factors model says both. There's kind of a back and forth there, and that's probably pretty much more accurate, although there'll probably be some folks one way or the other. The other thing to mention, I didn't mention, just to cycle it back, we do know that about 80% of those who are using heroin began with prescription medications. We talked about that. However, there's, as we continue to look at this, I talked about polysubstance use, there's some research out there beginning to grow that these folks actually were using other things like cocaine and marijuana for years or decades, even before, even as young as age 12 and 14. So they were at risk before they got to the point of using opioids. So if you just think about, if I'm sitting around here, I might think to use a glass of wine at a dinner, but I might not normally sit and say, you know what, I want to try some heroin tonight. You know, so when you think about the average individual and the risks associated, I might, but if I was using, for example, some marijuana and I was talking to the drug dealer anyway, and they said, well, you know, maybe we've got also one of this, I want to try that today. Remember sensation seeking. So you begin to see how the closer I get to risk factors, the more percentage of folks inadvertently slip that next step and the next step and the next step, versus having to take a bunch of steps until you don't go as far. Now, here again we have that transition timeline that we saw before. Same thing that you want to think about. Begin with an assessment, begin to deal with the substance use disorder spectrum is on the top. On the bottom, beginning some other conversations, such as engagement from the trauma perspective. Really begin, again, with engagement, build that safe environment. Can't get anywhere else until we're building that safe environment. And what are some strategies to do that? What are some strategies to motivate and engage and let them know that it's safe to trust you? Then once they're engaged, we want to begin to learn the management tools first. You want to have the tools with which to, you know, it's just like if I want to go explore a cave or go scuba diving, first thing I do is I go get the proper equipment. I go get the proper coping strategies before I go crashing off into the risky situations. Then later on, you got into the trauma treatment. Now, let's think about that for a second in the context of substance use disorder. I walk into my substance use disorder treatment and I go for a week, and then the insurance company says, you're cured, go home, you can better manage this on an outpatient basis. So now I'm on an outpatient basis trying to develop a relationship, trying to learn the skills while I'm still living down the street from my drug dealer, you know, and when am I going to deal with the trauma? What also then can sometimes happen is the trauma doesn't get dealt with until later, after they're off and into outpatient, when we might have been able to begin these conversations while they were in a safe and stable and supported environment. So for example, I've worked with folks before where you're doing your 1 hour outpatient session and then mom goes home and has to cook dinner for the kids. So you're dealing with the traumatic conversation and then, okay, now pack that up and just, our time's up and go make dinner. No, there's some challenges that get associated with dealing with the trauma treatment aspects with the lower intensities of treatment. So how to find that balance of what's needed, when, and how to support the range of things. So a couple of things to think about. Again, what can you do? Just reminders, because some things are worth repeating. Safety, safety, safety. Before, during, and after. I can't say it enough times. How do I engage that? How do I build that? How do I work with folks to support that? Then next thing is work to support the adequate treatment for mental health issues, for substance use disorder, the proper intensity and duration. It's a whole other lecture about how do we begin to work with our insurers and our funders to ensure that the appropriate care is offered and maintained. There are laws in Pennsylvania that support that. We actually do a little bit better in that in Pennsylvania than we do in some other states, but it is certainly a challenge, as you, again, if you turn on the news, you will hear. Engage in training to establish understanding of the workplace as a trauma-informed environment. If you don't already haven't already been doing some of these types of trainings in your workforce, it's a great lunch topic to what can I do to engage, and other simple things like creating a trauma champion for my office. Who is the person in my office who is designated to make sure that we'll get a training once in a while, or that we have somebody's going to review the forms, and to think about it from the perspective of how would somebody with a traumatic experience potentially get triggered, and is there a different way we could ask that, or maybe engage them for a little bit before we ask this question, you know, those sorts of things. Slow but steady wins the race. Again, I know sometimes people want quick fixes and all that, but treatment involves time, and building the relationship and doing the work. And I can't say that enough. but relationships matter. Healing happens in the context of the relationships. The engagement and collaboration is critical for success, for short-term and for long-term. Now, if you can't tell, I love this material. I'm always happy to talk further. My contact information is at the end here, and I want to save a moment to check in if there's any questions coming into the chat box. I'll be happy to begin to field a couple of those. Otherwise, we'll send you on to your rest of your lunch. So kind of questions come in. You mentioned that this is not based on the lack of a brain chemical that can influence people to use. I thought that some people might be more at risk than others. For example, people with ADHD are more likely to abuse a substance than someone who does not have ADHD. Okay, so what you're getting at there is, great question. So yes, there are many different types of risk factors, but ADHD per se is not a chemical deficiency. So for example, if I have ADHD, it's not that I'm Ritalin deficient. Ritalin may be an excellent support for this individual that can help protect them from that. It's not a specific chemical that you're deficient in to create the substance use disorder itself. Kind of like diabetes has an insulin deficiency issue. We've not yet found a specific chemical. Even depression, there was some old thinking that depression was a deficiency of serotonin, so we created medications that increase serotonin. But actually, as they've done more study, they found that some folks have too high serotonin, some folks are too low serotonin. So sometimes it's not about a deficiency, but about a regulation issue. And so the regulation issue is central to that. Great question. Another question I've seen is, I've seen people in recovery for years and then hear them not being able to do it anymore. What do you feel causes this? So, as I said, in the cases that I've seen, I'm going to start there, the only cases that I've seen who were in recovery for many years and then had a relapse had a pretty strong stressor at those times. One of the things I've always done when a patient comes back after even a period of time, I can usually trace them back about 6 months to triggers that started happening and changes that started happening about 6 months ago, where they didn't just pick up yesterday. It was before they picked up, they started isolating. They started feeling a little depressed. They stopped going to their 12-step support group or their church or their family gatherings. So you hear how there's a whole, if you remember the scale image where I said where are they at in terms of keeping secrets versus staying open, all those elements there, when you start to tilt the scale too far in the negative direction, over time, that's what creates that risk for return of the illness. Not that folks can't return without a major trauma, but you'll see that same kind of slide that I've almost invariably been able to trace them back at least 6 months. Have you heard of the therapy EMDR? And if you have, what results have you seen? Yes, I've absolutely heard about it. One of my supervisors was trained in EMDR, has used it, I'll say effectively. He always presented it in the context of this is an experimental tool. There's a range of tools out there. Let's try this one, see how it goes for you. I've had some differing responses to folks. Some people feel that it's immensely effective, and other folks, I've actually had somebody say, it kind of flooded me with some feelings that I wasn't expecting. And so it is one of the ones that's known out there for trauma. There's other folks that are also taking a look at that. That's not just the eye movement as curative, but also that the exposure to the traumatic event and pairing it with the sedating imagery is part of the curative factor. The other thing that they're thinking about as part of the curative factor is I don't want to get too technical here, but the bilateral brain stimulation. So there are other ways to engage the left and right hemisphere integration besides just the eye movement. So sometimes folks will just tap one shoulder and the other. They sell kind of, sounds bad, electrodes that you'll hold in each hand that will just kind of, it's not like a shock, but like a little buzz, so that it kind of stimulates left to right hemispheres of the brain. So it engages the same practice of integrating the left and right brain hemisphere. So I think there's some value there, and my position is always give appropriate informed consent and work with the tools, and if the first tool doesn't work with the next tool and the next. It's certainly been, over the years, more established with trauma. There's some beginning work out there with it with SUD, although that's not as widespread and robust in the literature that I've seen. One other here. There are people with chronic pain that is most effectively treated with narcotics. You have information or statistics on increase in suicide due to their inability to obtain prescriptions to manage their pain. This is one of the things that I have not seen statistics of change of suicide. This is indeed one of the challenging issues that's been going on out there, as folks have gone widely from not using medications to giving away opioids very freely to trying to rein that back in. So when I get a toothache and my dentist gives out 90 days of Oxy, it's very clearly not appropriate. And so I know the state has done some good work on developing guidelines about, as has the CDC and the FDA, given out guidelines in my longer version of this talk. There's the FDA warning labels that got changed on this. Make it very clear that it's not about never using opioids, but use them judiciously, use them carefully, understand the roles and when are they working. One of the other things to think about with this, though, is at this stage, there is no convincing evidence that opioids work for chronic pain. Because of the tolerance issue, I will have to keep using more and more and more because it will lose effectiveness. And worse, and this is tricky to explain, but the technical term is opioid-induced hyperalgesia. So what it means is, in English, is that when I start using opioid for a while, it actually makes the pain feel worse. So I actually have to use more opioids because of it. It comes like nails on a chalkboard. And so very often folks who are getting to very high levels of opioid use, while that might have been very helpful in the early stages, when it gets to a more advanced stage, even where they're not going out and steal for their opioids, they might actually get to the point where a medication holiday and tapering and things like that might actually give more relief because of the tolerance issue. So again, that's actually another whole talk that I do on the narcotics as well, and what are some of the non-opioid approaches. I would not recommend just cutting off cold turkey if I have opioids. You want to, as I talked, engage with these other supports so that the pain can be managed, effectively. Great questions.
At this time, we are going to close the webinar. Please join me in thanking Dr. Martz for donating his time and his expertise to talk about this extremely important and relevant topic to survivors throughout the Commonwealth. The webinar will be available at a later date, a recording form for those who want to review it again or those who missed it. But thank you very much, everyone, and enjoy the rest of your lunch.